Hello and welcome everyone to our sixth topic in Nikui's Project Firstline training series for our frontline workers, COVID-19 and infection control. Today's topic is new COVID-19 strains, vaccinations, and safely using multi-dose vaccines. Before we begin, please note that this session will be recorded for educational and quality improvement purposes. Nikui will be utilizing the recording to continue to share and educate frontline healthcare workers throughout this pandemic. Thank you. We are very pleased that you could join us today, and we hope that this forum provides an opportunity for you to gain knowledge and foster best practices as it relates to infection control. During each session, we will hear from our experts as well as offer opportunities for you to ask questions regarding the topics covered. My name is Melissa Watson, and I am the Public Health Project Assistant here at Nikui, and I will be your host today. If you have any IT difficulties during today's call, please chat directly to Noelle listed under comms and events in the direct chat, and she can assist you. Finally, if you could, please enter your name, UIO, or external organization, and any tribal affiliations into the chat box so that we can get to know each other and also count your attendance. Our agenda today features a brief recap of Nikui as an organization, Project Firstline, as well as our Project Firstline team. And we will then move into our training on COVID-19 vaccinations and multi-dose vials, with which we are excited to welcome Dr. Abby Carlson from the Centers for Disease Control and Prevention as our special guest. Jennifer Thompson from Native American Connections will also provide a UIO perspective after our training as well. We will then be divided into groups with 3 breakout rooms to discuss posed questions further. Finally, we will wrap up as a group to share our thoughts as well as ask questions as time permits. As I would like to remind everyone that as we go through the trainings, you will see information sourced on each slide. We will be sharing all of our resources, not only in the chat today, but in the follow-up email with a recording of this presentation and the slide deck as well. To begin, we have a background on Nikui. We are a national nonprofit organization devoted to the support and development of quality, accessible, and culturally competent health and public health services for American Indians and Alaska Natives living in urban areas. Nikui is the only national representative of the 41 Title V UIOs under the IHS and the IHCIA. Nikui strives to improve the health of over 70% of the AIAN population that lives in urban areas, supported by quality, accessible healthcare centers. We would also like to thank the Centers for Disease Control and Prevention for their continued support. Project Firstline is a national collaborative led by the CDC to provide information on infection control training and education to frontline healthcare workers and public health personnel. Nikui is proud to partner with Project Firstline. The contents of this program do not necessarily represent the policies of the AAAHC accreditation body, OSHA, CDC, or HHS, and should not be considered an endorsement by the federal government. Now we would like to reintroduce our Project Firstline staff here at Nikui. Dr. Kimberly Fowler is our Vice President of Technical Assistance and Research Center. Zipporah Fuller is our Director of Technical Assistance. Evelina Maho is our Public Health Program Manager. Diana Pejuan is our Senior Project Manager. Tiffany Stark, our Public Health Program Associate. Noelle Zelke is our Communications Associate. Alex Zamo is our Statistician, and Karen Kwok is our Subject Matter Expert. And today we have our training that is being led by Dr. Abby Carlson. She is an infectious disease doctor from the Centers for Disease Control, and she serves as the Infection Control Advisor and Subject Matter Expert for Project Firstline, CDC's new training collaboration for their healthcare infection control. She advises on the development of the Project Firstline curriculum, supporting resources, and the training modalities, and we are pleased and excited to have her here today. And then next, I would also like to welcome Karen Kwok with us, who is our Family Nurse Practitioner and Technical Advisor, Subject Matter Expert. She has her master's in nursing and public health and a national certification as the family nurse practitioner with over 20 years working in health equity with communities, including UIO patients. She also has direct patient care and service deliverable operations workflow in infection prevention and control. Next, we want to recap what is Project Firstline. Project Firstline is CDC's national training collaborative for healthcare workers focusing on infection prevention and control. Every frontline healthcare worker deserves to understand infection control principles and protocols so they can feel confident to protect not only themselves and their families, but their patients, facilities, and communities. Project Firstline is designed to help frontline healthcare workers to gain that confidence and knowledge through these training collaboratives. Lastly, we would like to also provide you with our post-evaluation survey link. We will be providing the link in the chat now, as well as at the end of the session. We ask if you could please complete our survey to let us know how we can serve you better. Your evaluation of the training content and delivery will enable us to meet our training needs and improve the quality of our program for you. So with that, I would now like to hand over the training to Dr. Abby Carlson.
Thank you for that, Melissa, and hello, everybody. Just a real quick review of the objectives. We're going to talk about SARS-CoV-2 and its strains, or variants being the other word you often hear for that. And then we will very briefly review available COVID-19 vaccinations, really in the context of how to safely use multi-dose vials of vaccines during vaccine administration. And then our other goal is, of course, to encourage your engagement around vaccines as a part of infection control, and to share with you some of the resources that we have, some of the toolkits, a lot of things actually on the web that are available to help you out with your programs. So if we go to the next slide, please. We're going to start with the strains and vaccinations. Next slide. So understanding variants, next slide. I want to start in this topic by really just quickly reviewing the parts of a virus. Some of you might know this from your studies before, but it bears repeating, because as we go away from our education, we slowly forget some of these basic things. So the basic structure of a virus contains two parts, and likely for SARS-CoV-2 for sure, a third. So the two parts that are common to all viruses are genes and proteins, and the instruction booklet genes, I like to think of them as like the instructions for making the virus. All of that is where the variant conversation will really focus today. We have the proteins that are made out of the genes, and then those proteins both protect the genes, those are capsid proteins, and they help the virus move around and help it make copies of itself. And that can be contained within the virus, or sticking out from its size, or built when the virus goes into a cell. So genes and proteins, all viruses have those two things. The third that is an optional is the envelope, and the envelope is made primarily of fats, just like the fats in our own bodies. And those fats protect the genes and proteins inside. And also serve as the layer that holds the proteins, which will help the virus move around, get into the body, get into cells, etc. It's that fatty layer that also makes it pretty easy to kill COVID-19, SARS-CoV-2, and other envelope germs, because all you need is soap and water to help dissolve that layer, break that layer up, or even carry the virus off the hands. And alcohol will do the same thing. All right, so having established the basic parts of viruses, we can go to the next slide. We can talk about how new COVID-19 strains develop. So, like we said, those genes are the instruction booklet that the virus uses to make copies. And when the virus copies itself, obviously it has to copy that instruction booklet too, so that the virus, the new virus, can go out and make more copies of itself. It's a exponential process and a cyclical process. So when it makes copies though, so when it tries to make a copy of that genetic code, that copy develops mistakes. And you can think of it like a child copying out a book for school, right? They'll get most of it right, but they might get a word wrong here, or they might spell something not quite right. Maybe they'll miss a whole paragraph. That is exactly what happens with genes. Some of the code gets left out. Some of the code might get changed. It may be as much as a single letter, but it's enough to create a problem. So the proteins, oftentimes there are some proteins that the virus has that work to follow along with corrections. They're the teacher trying to find the corrections in the code that they need to make. But just like teachers, they aren't going to find all of them. And some of the proteins are really not good at finding those mistakes. And in particularly in viruses, the virus is such a basic structure that it doesn't really have these advanced proteins to find those mistakes. Unlike in human beings, where these mistakes also happen, but we have a very complex system to correct for and attack those mistakes. And that the body is designed in part to find cells that have made mistakes in copying their genes. Viruses don't have that. They have very rudimentary, very basic proteins that do it. And so those mistakes get missed. But viruses then are forced to build the virus according to what is written out. It's not like they can recognize that mistake. And they build the mistake into the new virus. Usually when it's essential, it's into a new protein is really what we're talking about. So what happens is a protein that might have had a one little amino acid, which is a building block of a protein. So one little chemical structure here suddenly has a different chemical structure there. And it might seem like a small change. Sometimes it is, sometimes it doesn't matter at all. But sometimes it completely makes the virus non-functional. The protein can't fold the way it was supposed to, can't work the way it's supposed to, the virus dies. And sometimes it can, and now it's changed. And so the way the virus interacts with the body, interacts with the environment, et cetera, changes. But every time you get a new mistake, every time the virus is built with a mistake inside of it, that's a new strain. So every time you talk about a variant or a strain, it is something where a copy of the virus is somehow different than the virus you knew before. And the genes have changed in some way. All right, next slide. So viruses constantly change. This actually, we estimate that every infected individual sees every strain in their body at least once during an infectious course. We expect mutations to occur over time. We expect viruses to adjust as they travel through human populations. That is why we have flu pandemics. That is why we have different colds every year. And you can get the cold more than once because new strains develop and the body not always can recognize that you've actually seen this virus before. It's different enough. Variants can emerge and then disappear, and we probably will see that as we go along. And as I said here, most strains never make it out of the body. So even though in an infected person, you're gonna have all of these mutations occur at least once, most of them will never come out of a cell. Most of them will never be breathed out. Most of them will never reach another person. And so this is why you don't see explosive numbers of variants all over the place all the time. There's a certain pattern to it because most of those variants never have the opportunity to go to the next person and make more of itself. The other thing to know though is because of all of that, there are still multiple variants that usually circulate. So it's not just one variant that's covering the globe. There's usually multiple different variants of a virus that are circling around. This is true for HIV, this is true for influenza, this is true for rhinovirus, which causes the common cold. All of these have different variants. Next slide. And this shows you how this goes over time. I don't want you to read the text. I don't even want you to read the numbers. I want you to look at the colors. And each color represents a different strain. And you can see how that balance of color has changed between January and the middle of March in the United States. So as time goes on, different variants are better than others at infecting other people. Different variants are exposed to more people than others. And as that goes on, that balance will change and we can measure and watch that change. Next slide. All right, so we had a knowledge check here. And if we want to go ahead and put up the poll. Oh, you guys didn't, sorry, there's a change in the poll. So end the poll. Sorry, that wasn't there's a change in the poll. So let me ask you this question. If you just kind of knowing what we had just talked about variants, do variants always infect other people? Yes or no? You can put it in the chat. No, great, great, great. Awesome. So no, in most variants, this is an important point, most variants don't infect other people. Only a few variants can really infect other people. Here's another question which we didn't talk about, but you might have a sense based on what we were discussing. Are variants always bad? No, good. Okay, great. So variants are not always bad. Some mutations are going to make the virus weaker. That might actually still make it easier to go between people, but the illness that develops in people is less deadly. So we see that sometimes, that the mutation makes it easier for a virus to travel between people, but if the disease that they get is actually not as bad as the older variant. And so those, in essence, with those mutations, we get lucky. So those are kind of some of the basic things to remember about variants. They're not always bad. They're not rare. They happen all the time, and we can expect them, which means we can also plan a bit for them. All right, next slide. All right, so what is being studied? So we've touched on these things. The public health is studying a number of things. We're trying to understand whether they spread more easily from person to person. We're just trying to determine which ones cause more severe disease versus which cause milder. One of the things that we always think about is, does our test still detect the virus the way we expect it to? With genetic testing, usually the answer is yes, but sometimes the answer is no, or it doesn't work quite as well. So it is something we always need to check. Do they respond to the medicines that we currently use? That's an important one. And some of the most worrisome mutations in viruses happen because they develop to make medicines ineffective. HIV is a great example of this for those of you who are clinically minded. But there are lots of viral mutations for which we are concerned about this specific problem. And then, of course, for COVID-19, and the talk right now is, does the vaccine work as well? That too is an issue. The good news is the way our vaccines are currently designed, it's relatively straightforward to make changes that might make an equally good vaccine for a variant. Much more straightforward than it used to be, but it's still a concern, and it takes time and testing, and that's why it's a pretty big deal. So those are the aspects of variants and strains that we like to consider. Next slide. All right, so do strains impact infection control? Is there a second part of this slide? If you want to click, see if there's a second part. Nope, okay, go back. Sorry, I just wasn't sure if I inserted the illustration or not. Okay, so the short answer for infection control in COVID-19 strains is no. N95s still work to filter out respiratory droplets and droplet particles. You still have gowns and gloves that keep germs from spreading. You still have ventilation that clears the air of droplets and droplet particles. And none of that depends on the small mutations that we see in the virus. And you can think of this as the basic structure of the virus that hasn't changed. It's like different breeds of horses, or different breeds of dogs, or different breeds of cats. They're different colors, they're different sizes, they're different personalities, but horses are still horses up to a point. Dogs are still dogs up to a point, and cats are still cats up to a point. And so even though there are a lot of these small differences woven in, the basic structure of the virus has not changed. All right. So that is my section. I'm going to pass it over to Karen now to talk about multi-dose vaccine vial safety.
Thank you, Dr. Carlson, for laying the foundation and the current status on the COVID vaccine and the virus variants. Now, bringing that science to clinical practice with our staff roles and responsibilities, as well as clinic operations for our administrative staff that are here in the audience. we are highlighting the importance of multi-dose vaccines and infection control with the launch of the One and Only campaign. Next slide, please. And so with the COVID vaccinations, there are multiple vaccines that are available. Currently, it's Pfizer and Moderna, and Johnson & Johnson are on hold given the safety concerns that have recently come up. And with the multi-dose vaccines that are available, we'll be reviewing more in depth how we each play a role in patient safety and safe practices in the clinical setting. Thank you. Next slide. For some of the vaccines that come in multi-dose vials, I want to highlight specifically that in our clinical practice that we will be preparing those vaccines apart from the patient where we have control of the environment, ensuring that it's safe and clean, making sure that we have the right equipment. But then what is very familiar to us clinical staff is making sure it's the right person, dose, route, medication, but then also practicing these specific guidelines that we'll be reviewing in the following slides on how specifically to administer from a multi-dose vial. Thank you. Next slide. And with these multi-dose vials in infection control, it's so important to ensure that the vaccine is clean. It doesn't get contaminated, even though there are multiple doses in which it will be used. And that's why it's so important that methodically the cleaning, the observation of that vial use, the equipment that you have available, the needles that are in use is maintained clean, that is safely used according to clinical practice. And you're also working with your clinical operations team to ensure that the available safety of the equipment is ready for you, that stockouts are avoided. And that might be a safety lock on a needle, for example. Thank you. Next slide. For multiple dose vials, they're different from single dose vials because there's more doses available in them. But I still want to highlight that even though you will dispose of a single dose vial after one dose, the importance of making sure that you again are looking at the vial before you administer, that vial is used appropriately as it was intended to, where single dose is disposed of after that single dose. For the multiple dose, that you're employing the proper clean technique and not using it between patients. You're using a different needle each time. You're cleaning the vial top each time. Thank you. Next slide. And so with the CDC's One and Only campaign, it's highlighting specifically how, as clinical staff, we are ensuring that it's one needle, one syringe, use only one time. But we absolutely need the support of our clinical operations team as well. Thank you. Next slide. This public effort to eliminate unsafe medical injections ensures safe clinical practice, and the guidelines that help us avoid transmitting diseases like MRSA, like bloodborne pathogens such as hepatitis C and HIV. It's important that as a team, all of us together, can focus on if there's problems in employing best practices, even on an individual level in clinical practice, that we report the problem and we work together with our clinical operations team, our quality improvement committees, on ensuring that we are constantly improving, that we are avoiding any near misses. Thank you. Next slide. Here are a couple of injection safety guidelines. And so my clinical operations team in the audience, I hope you're thinking of possibilities as to what are system challenges that we can help ameliorate, that we can help avoid to ensure that there is safe and successful completion of these individual tasks around one time, one syringe in use of the one needle. Through these guidelines that are developed by our operations team on staff competency, we will be avoiding needle stick injuries and ensuring that if there was an incident to occur, through our reporting systems, that we are abiding by occupational health policy and procedures, that we are ensuring that we always are having the clean, safe equipment available to do our job, and the environment that's conducive to ensuring safe patient care. Thank you. Next slide. Here is a resource that can be made available after this presentation, where you might find it helpful to post in your clinical setting to ensure that we are abiding by the one needle, one time campaign, and in keeping safe with our clinical practice, that it is a culture of safety and it's supported by the workplace environment. Thank you. Next slide. In this slide, there's multiple different points, but the ones I would like to highlight again, which we had reviewed just previously, was regarding the use of single and multi-dose vials, and also ensuring that when we are observing the safe clinical practice with a disposal of single dose vials after a single procedure, that still with multi-dose vials, we are ensuring that we are making the vial clean, using one needle with each patient, and ensuring that we are minimizing infection control, minimizing disease transmission. Thank you. Next slide. In the safety tips here, this again would be a resource that you can print, for example, in your medication administration room, walking you through the steps to ensure that you are having safe clinical practice in infection control, that you are reading the labels, and for a single dose that they are immediately thrown away if they're already punctured. And with multi-dose vials, that we are ensuring that the expiration date is listed, particularly for COVID vaccinations, given the time limitations, that we are documenting that, and in our safe handoff, that it's listed such that the next provider, clinician who is using that vial safely understands when that expiration time is up. The drawing of the vial with the dose is through aseptic technique, that you're using a new needle and syringe each time that you're administering it to a patient, that you're still practicing the same infection control techniques that we have reviewed on other presentations, like hand hygiene and disinfecting the vial by rubbing the diaphragm with alcohol, drawing up the correct dosing of the medication in a clean area. And after the procedure, that you're disposing of the equipment appropriately to ensure that there are no needle stick injuries. Thank you. Next slide. Oops, sorry. There. And so this is just a review again of safely administering vaccinations and reviewing the multi-dose versus single dose vaccinations, and then ensuring that the environment is clean. You are using the doses as recommended. Thank you. Next slide. So with this knowledge check, we can start the polls. The question is, a new needle and syringe should be used for every use of a multi-dose vaccine. True or false? And I'll give you a few minutes to answer the question.
Just a note, it looks like the poll's not working or haven't been updated, so we can just put that in the chat.
Okay. And so in the chat, you can just say true or false. Great, you're absolutely right. It is true. And so this is our last knowledge question. A new needle and syringe should be used for every time that you are removing a dose from the multi-dose vaccine. Thank you very much for answering the question, participating. Thank you. Next slide. So the resource listed here is, again, something that you can share more so in the staff training sessions that my clinical operations team might be employing on how to properly store and transport vaccinations. And then here you will find links dropped in the chat box that will allow you to continue with ongoing training and staying up to date with safe administration of vaccines. Thank you. Next slide. And here's at a glance another resource guide on appropriate vaccine administration and storage and handling. Thank you. Next slide. This is a continuation of resources, and specifically I want to point out there's been a question that has come up often regarding the clinic operation checklist resources, and there's a checklist here specifically for immunizations. You might be able to administer it during an interview, for example, on a self-assessment tool on safety of vaccine administration, for example. Thank you. Next slide. And lastly, this particular resource guide is highlighting best practices in vaccination, epidemiology, and safety. And so each of these resource guides will be made available in the chat box as well as after this presentation. And I hope you make it useful, not just in your clinical setting for staff reminders. We all need that in busy clinic practice, but that you might also be able to adapt it for your clinical operations regarding staff competency checklists or just in the adaptation of your clinical guidelines. Thank you for your attention. I hope you enjoy the training, and I'll now hand it back to Melissa.
Thank you so much, Karen, and thank you, Dr. Carlson. We appreciate both of your trainings. Next, we would like to welcome Jennifer Thompson, who is going to provide some commentary for us from a UIO perspective. Jennifer's joining us from Native American Connections. Jennifer, I'll hand it off to you.
Hello, everyone, and thank you for allowing me this time to speak. We definitely wanted to highlight our best practices here at Native American Connections. So we started with our vaccine program back in October. We do receive our distribution from Indian Health Service, and this has allowed us a lot of flexibility. So in the planning weeks leading up to administering the vaccine, a lot of it did center around infection control and employee training. One of the benefits is being a UIO and receiving supplemental funding from Nikui was we were able to kind of buy the supplies that we needed right away. We knew that we were going to be providing vaccines in our different patient care settings. So we have 23 different sites, 2 of which are residential treatment programs. We have 3 different types of emergency and homeless shelters, as well as different types of permanent supportive housing and affordable housing. And throughout our vaccine program, we've been able to go into all these different sites. However, it's taken a high level of care and coordination when it comes to that, in terms of working with those at those programs to see what the facilities are going to be available and what types of things that we need to do to, prior to setup as well as tear down. So we work a lot with our property managers, our program managers and directors when it comes to going on site, making sure that the supplies are there. In relation to safely administering the vaccine, of course, our show is taken on the road. So we administer some of our vaccines here in our clinic in our main facility, but a lot of the vaccines have been done off-site. With that is first and foremost is the proper training and education. We've implemented different policies to address knowledge in terms of utilizing PPE and at what level should we utilize depending on the patient care population or say the environment that we're going into. And the other thing that we also do is observation. So before anybody who's been added into our clinic team can actually be one-on-one with our patients, our supervising nurse practitioner will observe. The other process that she did implement to ensure that these offsite events go smoothly is everything is transported to the event and then they set up there. So in terms of the multi-use vial, for example, there was discussion back and forth of using, say, a multi-use vial adapter or drawing at the time. Well, because we coordinate everything and we set our appointment schedule well in advance, we're able to know exactly how many vaccines we need to take with us. And then at that time, the provider draws it. And then the medical assistant then labels all of the prints out all of the labels to ensure that we have a draw time and a max time that's on there. That's really important, not only for managing the actual doses, but in terms of wastage as well, because with early on in the program, there was limited availability. So we utilize standby lists and other measures to be able to not let any doses go to waste. Going back to the drawing at the time of the event, the other thing that we found successful, because we administer the Moderna, and while there's normally, you can get 11 doses in the vial, we found that to stay consistent, we have one provider who draws the doses for the day. We also do our scheduling in terms of 10 per vial. So that's another reason why we have the standby list, is to ensure that we always are using the vaccine that we're drawing. We're not overdrawing. And then if there is any, we've had a few instances where we were offering first doses the same day and more folks were interested. Well, in terms of transporting, storage, and handling, while we take all the necessary supplies, we have our data loggers, our ice packs, everything to keep the vaccine secure, we never take more than necessary. So if we ended up with more folks that needed to be vaccinated, we would then coordinate them to come over to the clinic instead of transporting a vial that may or may not have fallen without a range that then goes back into our inventory stock. One other, I guess I'll kind of close on when it comes to coordinating with infection control and say your sharps containers, your biohazardous waste disposal, the availability of flexible and funding to be able to make real-time purchases and enter into contracts was really significant for us, because while we were going at all these different locations, we had to ensure that we had all of not only the proper equipment, but also the proper biohazardous waste handling to be done for after the event. I could definitely go into more in depth. I think those are the main things that we try to do here, is really about staying consistent with the providers, ensuring high level of coordination when you're going on site. And that's what's worked best for our program, to be able to administer in excess of 1,000 doses with about a 93% compliance rate in terms of completing the series. So with that, if there's no questions, then I believe I will be turning it back over to Dr. Carlson for additional commentary.
Thank you so much, Jennifer. And if anyone does have questions, please feel free to drop them in the chat box as well, and we can direct them over to Jennifer or Dr. Carlson. But we'll take this time for a minute to have Dr. Carlson join us again to just tie everything back together for us before we go into our breakout rooms.
Yeah, so this seems at first glance like kind of disparate topics, but I think the theme of the hour is vaccinating safely, and vaccinating well. And you can see that putting to practice, in particular, the multi-dose vial safety can be a large coordinating challenge. And thinking through, as Jennifer and her team have done, how you're going to maintain all of those various needs for the materials, for the temperature storage, for the alcohol pads and sharps buckets, for everything else that goes into vaccinating a group of people can be quite the process. And I think that one of the things I would say is there are a lot of ways to do it right? I think we have this tendency to think of infection control as this series of policies and procedures that we all have to implement and you have to follow by the book. But rather than that, I think Jennifer's example was great because it's taking what your unique experiences in terms of the systems that you work with, in terms of the places that you travel with vaccine, in terms of the populations you're trying to serve, and really tries to put together an option that's best suited to you. And in infection control, the underlying hope for all of this is that as you gain your knowledge in infection control and infection prevention, you're going to be able to better know your options. You're going to know that you could do this, and those will be about the same risk or about the same safety. You'll know that you have the choice to put together two different types of systems, and those two systems will work, equally well. And so you can choose which one is better for your circumstances. And as you go along with this knowledge, I think it's going to become more and more evident just how all that comes together. I know I speak as somebody who's had a lot of formalized education in that level, but I've seen it on the ground with people as they gain knowledge, as they gain understanding. They're better able to incorporate some of this into their daily lives in ways which make their work easier and safer for everyone. So it's been a great presentation of topics from Karen and the case from Jennifer of what they are doing in their organization. And I think hopefully this will give us some foundation for discussion as we go into breakout rooms. So I'll leave it there.
Thank you, Dr. Carlson. And as Dr. Carlson just mentioned, we are going to get ready to go into our breakout rooms. We're going to separate out into 3 rooms, and we're all going to cover the same topic listed here. Is your UIO facility administering COVID-19 vaccines? And if yes, we're going to discuss about challenges and how you address them. And then if no, how are you supporting vaccinations as part of infection control in your facility? So there will be a pop-up that comes up on your screen now for you to enter into your breakout room, and we will join back together in about 10 minutes.
Dr. Carlson, you had left when we were about to hand over to you. So if you wanted to go ahead and share with us your thoughts, I know my team was here. You wanted to add to what Erin was saying, please go ahead and do that.
Yeah, no, just sort of asking in general, I think the question that I would have, and this is, I think you had answered it. Sorry, I'm sort of thinking about what Erin had just said, because I think you answered it kind of in my discussion or your discussion of who handles sort of the multi-dose vial management. And there is a group of people who are kind of handling the administration side of it. But I was thinking through kind of points where if I was a clinic manager or the charge nurse or somebody overseeing processes, the kinds of questions that I would think about asking that you probably have answers to are things like, how do you space people in the waiting room, which we've already, at this point in the pandemic thought about, but when you add a vaccination campaign on top of your usual people spacing, how do you process that many people? How do you, have the space and keep dedicated space for multi-dose vials, which should be separate from patient care. So one of the main points about multi-dose vials is that they should never be bought into a patient care space. And that means the patient room, that means the little bay where patients are going to get vaccinated, that means the table, or by the car if you're doing it outdoors. And I think that's probably the biggest one that people miss. And then obviously on the back end, handing them off. And so where do people exit, and are the patient flows correct? How are sharps buckets handled at the end of the day? Do we have enough sharps buckets? And if we don't, what do we do? Some of these other things that I think are just interesting to think through in the process. But the beginning of a program like this is really thinking about what are, from the infection prevention side, is what are the infection prevention risks? Have I thought all of them through, sort of from the beginning to the end? And how do I address them as they come up, which is the other thing, the things you don't anticipate as you go along. But it was great to hear about your guys' experiences.
Thank you,
Dr.
Dr. Carlson. I'll hand over. Oh, go ahead.
Yeah, I just wanted to add, that's great. And one of the things that we found was taking our time. The goal, everybody's goal is to get as many shots out as possible. But it took a lot of care and coordination where we thought we could run 3 patients every 15 minutes. Well, no, we ended up running 1 every 30 minutes. And then we've slowly built up that capacity to being able to schedule 3 at a time every 15 minutes. And that was kind of a learning experience for us, as well as communication, so that myself and the other leaders understood, okay, we're not going to be able to see 50 people a day. Right now, we're only at 20, but these are all the things that we're working out, and really leaning on our providers, our clinical staff, to say what's working for them and what isn't. And then for us, going back and checking the guidelines and utilizing our professional resources to kind of run through scenarios like, this is how our staff wants to do it. Do you see any holes in this? Otherwise, we're going to go forward.
And I think too, the pandemic has really brought out for people a few things. Erin was talking a lot about how you have a lot of new staff who have to do a lot of administrative work on the back end to make this program work for your team and not burn out people who are already pretty burnt out from the very long pandemic. And so how do you, again, just sort of this might seem unrelated in the realm of infection control, but as an infection control person, the questions you start asking are, how do you help those people understand the infection control processes of your clinic, not just related to vaccination, but as a whole? How are you training people and educating people? As new people take on roles, so for example, you might have people giving vaccines who never have given vaccines before. How do you train those people? What sort of training do they need? And particularly for COVID-19 vaccines, which are they're not our typical vaccines. Usually in the United States, we use single dose vials. We don't have these very complex storage requirements that we had early on with Pfizer, those sorts of things. So you're not only training a new person into a new role, but you're training a new person into a new role that most of us already find difficult as clinicians to be trained into ourselves. So there's a lot of layers to that too. That's just the other end of things that I was thinking about.
All right, thank you so much, Dr. Carlson. We might go a little bit over time, but I realize that this topic is a very important one. I am going to transition back to Melissa so we can get like a 30-second group report. I know for our group, we both had Kim Hendel, we had Erin Wakini, and we also had Lori on our call. And basically, they've had no issues with infection control around vaccinations. They have had a larger number of folks show up who were not prior patients, and they had to work on a lot of the administrative stuff, pretty much kind of like what Jennifer identified going through. So I will hand over to Melissa to coordinate the other 2 teams and report. Mel?
Kaylee, would you like to report out from our room?
Yeah, I can really quickly.
Sorry, Haley and Kaylee.
Oh.
Kaylee, you can go first, and then Haley, you can follow up. Sorry, ladies.
Okay, I can go really quickly. I think one thing so we had Carrie and Jennifer, one from Bakersfield and Native Connections. And I think one thing that really like stood out was like there's no provider in-house for the vaccination clinic, and they used EMT. And so they had to adjust with that. And then another thing was that they had all services still going on at their urban Indian center. And so I think Carrie mentioned that there was only 16 people for all services. And so they had to choose one day to do the vaccines. And so I think Jennifer asked a lot of important questions about how this is done and how she can also mimic that kind of same how they administer their vaccines and that kind of a flow that they have. Okay, I think that's good.
Okay, I'll go really quick next. So we, in our group, we had Melissa from the Tucson UIO, and then we had Nancy from Fresno. And so really what Melissa was saying, that like with the vaccine rollout, like they were having some difficulty, you know, making sure that social distancing was in effect. And then Nancy just really talked about how they were mostly using Moderna, but it's really cool because now they're having more access to the Pfizer. And so they're actually going to reach out to their community, high school, and they're going to be distributing to like the 16 and 17-year-old population. And so they've had a really good like 100% rate. And Nancy was also talking about how they've, you know, traveled to different areas in their community to make sure that they can get as many people vaccinated as possible, which is really, really cool for like their outreach efforts. And so then for best practice, for Fresno, they were having some difficulty just whenever the transition went from serving just a native population to then moving into like non-natives can get the vaccine. And so they've just really been trying to utilize like social marketing and things like that to, you know, try to get everybody in the community vaccinated. So really the only like additional support is just more people, you know, being able to like utilize that people to go out and like vaccine. But other than that, we had a really good discussion. So
thank you that, and thank you for all of your report outs and all of your participation today. I know that we are a little bit over time, but we do appreciate you all staying on. I know we could probably stay on for another 2 hours discussing this, so it is very important. We appreciate your attendance today, and a special thank you again to Dr. Carlson and Jennifer for their training and commentary today, and as always to Karen as well. And we'll just end shortly with our survey. I see that Diane just dropped it into the chat too. You can just take a few minutes to fill out our survey about today's training and then also what you'd like to see in the future. We do greatly appreciate that. And thank you all again for your time and have a wonderful day.